Welcome to Epstein Becker Green's webinar, Managed Care and Behavioral Health, part of Behavioral Health in our series. We're pleased to have Epstein Becker Green's Jackie Selby, who is a member of the Healthcare and Life Science Practice in New York, presenting today. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are also welcome to submit questions directly to Jackie following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. At this time, I'd like to turn the webinar over to Jackie.
Thank you, Lisa, for the introduction, and it is my pleasure to address managed care and behavioral health today. The overview of the presentation, first we'll consider some background materials on managed care products and their regulation, then go over some delivery systems for behavioral health care services. Next, I'll address some key health care reform initiatives related to behavioral health and certain barriers or challenges to those reforms. And then last, some related developments in Medicaid and behavioral health, since Medicaid is the largest payer of behavioral health care services in the country. This slide shows some examples of managed care products, most of which include behavioral health services as a benefit. The first here is government products and includes Medicare Advantage or Medicaid managed care and some duals products like FIDA and PACE or CHIP for children. The second tier are exchange products offered by qualified health plans, whether federal or state exchanges, and to individuals or groups. And then the last tier, commercial, more traditional products like HMO or PPO offered to fully insured or self-funded individuals or groups. These managed care products are offered by various types of managed care organizations, or MCOs. I'll call them for purposes of this presentation. They can be HMOs, PPOs, QHPs, and other types of providers. Note that the products as well as the MCOs themselves are subject to different laws. So this results in different legal analyses being required based on the specific product or plan at issue. For example, network access requirements are different for Medicare Advantage versus Medicaid managed care, and commercial fully insured versus self-funded products. The utilization management rules vary. Claims filing deadlines and prompt payment requirements vary. For example, most prompt pay laws don't apply to self-funded business. Denials and appeals processes can be different. Dispute resolution, patient hold harmless obligations, and confidentiality requirements can all vary. Now, this is a really basic diagram of a delivery system for managed care. So the MCO would offer various products like some of the commercial or exchange or government products we just discussed, and have agreements. Those lines would be agreements with different types of providers like physicians, hospitals, or ancillary providers. Next slide. So behavioral health services, however, could have a different delivery system. They're often carved out of a managed care organization's agreements with providers, and they are then provided and managed separately by a specialized behavioral health organization, or a BHO, which may or may not be affiliated with the MCO. And those BHOs often have their own network of providers with their own separate agreements, pay behavioral health claims for those providers, and perform utilization management or medical necessity review for those services. Another example of a carved-out service would be pharmacy with PBMs. And the BHOs likely have multiple MCO clients that access their networks, which makes the consistency of their contract terms with their network difficult. And thus my point really is, not only does applicable law vary by product and payer, but the contract terms also vary by product and payer. And this is the same diagram, just with the carved out behavioral health services delivery system added in. So in green, you'll see the BHO then has agreements with some of the same providers, in this case, provider B, C, and D. And some of those providers have agreements with the MCOs directly for the medical services. There's some overlap, but not total overlap typically. The next slide. So you'll see that providers who provide both medical and behavioral health services, for example, the hospital on the prior diagram, may have different agreements apply to services that they provide to the same individual. So if they're providing medical services to an individual, one agreement applies. If they're providing behavioral health services to that same individual, a different agreement could apply. Now, the terms of both such agreements are likely to be different in some ways. For example, the policies and procedures might be different, like clinical criteria used or prior authorization requirements for the services, or even eligibility verification for those individuals. Claim filing deadlines may be different, and of course, reimbursement terms are likely to be different. And interestingly, the term and termination provisions typically wouldn't align necessarily because, like I said, the BHOs often have more than one MCO client, and providers may end up actually being in network for medical services, but not in network for behavioral services for the same individual or population, and vice versa. I've had clients end up in that situation. Dispute resolution provisions could be different. Some offer, arbitration versus litigation. And a unique challenge comes up when patients present with both medical and behavioral health conditions at the same visit. So it's hard to know for the parties which agreement applies. The diagnosis code, for example, can be medical at admission but changed to behavioral at discharge or vice versa. It's actually not that uncommon, and all of this can get, of course, confusing. Next slide. Now we'll talk about some health reform initiatives related to behavioral health. The first one is the Affordable Care Act mandates coverage of behavioral health services as an essential health benefit. And this is true for private plans and Medicaid plans. And by behavioral health services, we mean mental health services and substance use disorder treatment, the latter for most plans, but not all. And then next, the MPEA, the Mental Health Parity and Addiction Equity Act, essentially requires that behavioral health benefits be treated the same as medical benefits. And Leslie Young covered this last week in her webinar. But at a high level, that means financial requirements like copays and deductibles are supposed to be the same. Quantitative treatment limits like visit limits should be the same, and non-quantitative treatment limits like medical management and medical necessity review should be the same. And then lastly, there are final mental health parity regulations for Medicaid and CHIP due out tomorrow, and they are expected to require parity regardless of the delivery system. The goal is to create consistency between the commercial and the Medicaid markets. Other reforms include population health and value-based payment, and both of these types of reforms require coordination between the medical and the behavioral health services. For example, ACOs, whether Medicare or commercial, and primary care medical homes. Medicaid expansion in itself has resulted in increased provision of behavioral health services. The expansion population has significant behavioral health needs. There was an article today or yesterday in a North Carolina paper. Since North Carolina is considering Medicaid expansion, CMS is promoting the benefits for behavioral health treatment if they do that expansion. So quoting from that article, this is CMS saying, not only will more of these individuals be likely to receive treatment, but this coverage expansion may reduce other medical costs, increase employment productivity, lower overall rates of depression, and indirectly reduce criminal justice costs. CMS also said that one study of low-income adults for this population showed that 30% had serious mental illness and are likely to receive treatment if they have Medicaid coverage. Some states are still transitioning Medicaid or the new Medicaid expansion population to managed care, although 80% of all Medicaid is now under managed care. Some states, however, are going in the other direction. For example, Connecticut has moved Medicaid out of managed care. And some states, even if they have managed care, are in the process of carving in behavioral health to that managed care for the first time. Previously, the state was paying for those services directly. Although, for example, in New York, even though the government's carving it in so that they're paying managed care organizations for it, the managed care organizations themselves can carve it out to another vendor. And there are also increased numbers of state Medicaid waiver and demonstration projects. As of September 2015, there were 55 approved Section 1115 demonstration products in 18 different states, many of which involve behavioral health services. And lastly, there is definitely an increase in federal level regulation of Medicaid managed care. For example, CMS proposed a broad-reaching rule last May that seeks to align Medicaid managed care with commercial Medicare managed care markets. So there are some unique challenges related to such health reform initiatives. Two hallmarks of healthcare reform, which are care coordination and the integration of behavioral health care with primary care, are proving more challenging for various reasons, including the fragmented regulation and delivery systems, confidentiality requirements being more stringent for behavioral health, and Trish Wagner covered this in her webinar 2 weeks ago. Another level of coordination is required to integrate mental health and substance use disorders, since they've historically been regulated differently, and measuring quality improvement and cost savings for purposes of value-based payment initiatives are more difficult for the same reasons. Lastly, compliance with the mental health parity law is proving challenging for pretty much the same reasons. Now, switching just to Medicaid specifically, as I mentioned, it's the largest single payer for mental health services in the U.S., and it increasingly plays a larger role in reimbursement for substance use disorders, given the Medicaid expansion population. Here's some data with respect to Medicaid spend for enrollees with behavioral health diagnoses, but it's back from 2011. I haven't seen more recent data. I think in the interest of time, I'll skip the rest of this slide, but on the next slide, it's really the bottom line that total Medicaid spending per enrollee is almost 4 times as much for enrollees with a behavioral health diagnosis than for those without a behavioral health diagnosis. So the next slide, please. Given all this, many states have ongoing pilots and initiatives to improve access to behavioral health and improve quality and reduce cost of behavioral health services. And taking New York as an example, because approximately 1/3 of the state, New Yorkers, have Medicaid as their health care benefit plan, and New York has multiple Medicaid managed care projects involving behavioral health services taking place right now. One is DSRIP, which stands for Delivery System Reform Incentive Payment, and that includes approximately $8 billion over 5 years in federal incentive payments for providers to organize and take on projects, some of which I should say include integrating primary care with behavioral health. There have been about 25 of those provider systems in the program. It's just passing 1 year. And there's another product called HARP, Health and Recovery Plans in New York for severely mentally ill or substance use disorder patients as of last October. and this offers home and community-based services to address social and non-healthcare related challenges that accompany behavioral health issues. And finally, New York is also planning an IDD FIDA product for the intellectual and developmentally disabled population. And I think with that, it brings me to the end of the 15 minutes. So thank you for your time today, and please don't hesitate to contact me if you have any follow-up questions. Thank you very much.
Thank you, Jackie. This concludes today's webinar. We have a reschedule of a behavioral health crash course webinar, Investments in Behavioral Health, Drivers and Outlook. It's scheduled for next Tuesday at April 5th. If you have not yet registered, please feel free to do so. Information will be sent out today. In approximately 2 to 3 business days following this webinar, we will communicate the availability of the webinar recording and access to the PowerPoint materials. Thank you for attending.